So, good evening, everyone. Welcome back. On behalf of IAP Allergy and Applied Immunology chapter, I would like to welcome you all once again for this very interesting Biologics series. And we have seen for past 2 days or past 4 hours that how biologics are now coming up as a new weapon or as a new armamentarium in our allergy clinic or allergy management. But it is also very important that as these therapies are very effective but costly and they are having some certain indications only, selective indications only. So that is why we need to discuss in length about these biologics. Today we have uh, a extreme, I will say extreme learned speakers with us across the globe. So we will be having few speakers from United States, France, and simultaneously from India. And we are having an excellently talented moderator with us, Dr. Sonia Bhatt. So Dr. Sonia Bhatt is senior pediatrician and allergy specialist from Agra, and she is currently the professor and head Department of Pediatrics at FH Medical College, Agra. I would request her to please moderate the session. Dr. Sonia, you are welcome.
Good evening and a warm welcome to all the dignitaries present here and all the delegates who are watching this on YouTube Live. And again, as Dr. Neeraj said, a warm welcome to you on this excellent webinar series. And we are at on the last day of this series. And as it has been already told that now we know about the biologics, the basics of biologics, the molecular biology, their cause, their choosing the right patients. And we've also discussed few conditions where biologics are already being used in past 2 days, like in asthma, in chronic sinusitis with nasal polyposis. And today we are here with a galaxy of experts who are going to guide us further in this series. And I think Dr. Narayan sir has also joined. Yes, sir.
So I would like to invite Dr. Narayan Reddy sir, who will be chairing the session today. So Dr. Narayan Reddy sir is the Honorable Secretary of IAP Allergy and Applied Immunology chapter, and he is a senior pediatrician allergy specialist from Hyderabad. Dr. Reddy sir, please.
Yes, sir. Good evening, everyone. So it is a happy moment for me. This is the third webinar on biologicals, is a targeted therapy in allergy, future treatment in allergy diseases. And it is very useful and practical for all practical pediatricians and allergy specialists particularly. So it is evolving and the future therapy for allergies. Of course, as you see, urticaria, atopic dermatitis suffering. They are suffering like anything. The targeted therapy is very it is helpful. The quality of life improves, and overall, of course, most of the satisfaction patient and doctor also. I think it's very important, very informative to all allergists, and to upgrade the knowledge and ethical practice, to do ethical practice. This is very important. So emerging the indications of the future of biological, particularly. So many the speakers are very well known, Indian abroad, and they are very well experienced in this field. So I hope it is very useful. All the best for everybody. So I hand over to Neeraj sir.
So thanks a lot, sir.
Dr. Sonia, please take care.
Yeah. Okay. Thanks a lot, sir, for your kind words. And now I think I won't be coming in between academics and the delegates. So let's straight move to the first topic, which is a very important topic, because we all know that urticaria, whenever it's acute, we keep on seeing it, we treat it. But when it becomes chronic, it's persistent, it's a very distressing condition for the patient, as well as the treating physician. Even it becomes a problem for allergists also. So to enlighten us on this important topic, biologics in chronic urticaria, omalizumab and beyond, we have none other than Dr. Vinay Mehta. Dr. Vinay Mehta, sir, is a US board certified allergist, immunologist. Currently, he's working in Allergy and Asthma Association in Southern California. He has got trained at world-renowned centers like Mayo Clinic and Princeton University. He has served as primary investigation on numerous phase 3 trials. Apart from so many achievements, I've always remember sir as a very humble teacher of mine. Some won't remember, but I was a 2019 batch student of his in CMC, and is a person who's so full of knowledge yet so humble. A warm welcome to you, sir, and you may take over the stage. Thank you, sir.
Okay. Thank you, Sonia. Thank you, Neeraj, and thank you, Dr. Reddy, for allowing me to for giving this talk. So this is a very important subject. A lot of us, both in allergy and also other specialties, will encounter patients with chronic urticaria And as Sonia rightly mentioned, it is something that is often frustrating for both the patient, family members, and also for us as treating physicians. So we'll talk about uh, two biologics that are currently approved for chronic urticaria. But before I do that, just want to again highlight, the extent of the problem. And so, as a background, we know that chronic urticaria, fortunately, is not that common, but still about 1% of the population, which has a significant impact. When you think about, 1% of your population at any given time, by the way, will have chronic urticaria. So that has a significant impact on quality of life, including school performance, work performance. Very important to emphasize that it is chronic. It doesn't mean that you'll have hives every day, but it means that the hives will recur. So there may be, you may have weeks and weeks of hives, then a break, and then it comes again, weeks and weeks of hives. Average duration is about 2 to 5 years. And important to recognize that about 50% will not respond adequately to even high dose, 4 times the dose of antihistamines. And so a lot of patients become depressed, they become anxious, they don't sleep well, there's a lot of stress. What's going on, doctor? There's something wrong and no one can figure it out. So it's important to understand, what causes chronic hives. So it's a mast cell disease. You have degranulation of mast cells, which release histamine, which is only one mediator, but also various other mediators, leukotrienes, tryptase, prostaglandins, platelet activating factor, pro-inflammatory cytokines, and vasoactive factors. There are a lot of things being released, not just histamine. And although it is a primary mast cell disease, there are other cells that also participate: basophils, eosinophils, B cells, T cells, in particular. And it's important to recognize that mast cells can have multiple pathways for activation. So on the left side, you have non-immunological activation. These are things where the immune system is not involved. These are substances or pathogens that directly activate mast cells, like infections. We know that with acute urticaria, a lot of times they will activate the bacteria or virus will activate toll-like receptors. We know that certain drugs like radio contrast media, vancomycin, can also directly activate mast cells. Opioid receptors, platelet activating factor. There's other drugs, through the MRGPRX2 receptor can activate mast cells as well. So it's important to understand that it is not all Ig mediated. Now, where the immune system is active, and this is where we'll focus on, yes, mast cells do have Ig receptors where antigen can bind IgE, cause cross-linking, called degranulation. And this is through the high affinity Fc epsilon R1 receptor. And this is what we'll focus on. So Fc epsilon R1 is an important target in chronic urticaria. And it also plays therefore a role in potentially responding to the treatment. Now, there are 2 types of patients with chronic urticaria. They have 2 types of autoantibodies. So before I get into that, remember the classic type 1 immediate hypersensitivity pathway is when you have pre-existing IgE antibodies that sit on the mast cell receptor. And then when the same antigen directed against the IgE binds the receptor, there's cross-linking of 2 adjacent Ig molecules, and this will cause mast cell degranulation, as well as basophil degranulation. Now, in chronic urticaria, it is not due to an allergen. That's very important. This is not an allergen-mediated disease like foods and insects. That is not chronic urticaria. In chronic urticaria, you predominantly have 2 types of autoantibodies. You have IgE antibodies that can be directed against things like thyroid, interleukin-24, double-stranded DNA. This is what we call type 1 phenotype, where the IgE antibody directly will activate the mast cell receptor, Fc epsilon R1, and cause mast cell degranulation. So that's type 1. But you have also another type where you have IgG antibodies. So these IgG antibodies could be directed against IgE, as illustrated here, but it could also be directed directly against the high affinity mast cell receptor, Fc epsilon R1. And that's what we call type 2B. So these are the two endotypes that cause the vast majority of chronic urticaria. Again, what is chronic urticaria? Well, most of the time it falls into chronic spontaneous urticaria where there is no known cause. That's vast majority, 80, 90% of the time, you're not going to find a cause. You're going to have recurrent hives. You could have recurrent angioedema. You could have both, persisting more than 6 weeks. And it is, granted, it is more common in adults compared to children, but even children can develop chronic urticaria. And again, it's important to understand that it is a chronic disease, average duration 2 to 5 years, and about 50% of patients will not respond adequately in spite of 4 times the dose of antihistamine, H1 antihistamine. So how do you assess it? This is important because especially when we talk about biologics, not every patient needs to be on a biologic. How do you determine when to start a biologic? Well, you need to have patient-reported outcomes. So there are 3 scales, 3 measures that we typically look at. One is called the hive score, HSS7. That is the weekly hive severity score, where the patient every day scores their level of hives from 0 to 3. 0 means no hives, 3 means more than 50 hives in their body. So this gives you a score of 21 in a week's time. We also ask patients to rate their itch. So this is called the weekly itch score. 0 means no itch, 3 means intense itch to the point that it interferes either with their sleep or their daily activities. And that's also scored out of 21. And then the urticaria activity score is really the sum of these two. So that's scored out of 42. And what our goal is, you want to reduce the score to 6 or less. That would be good control or well control. But even more ideally, we want an activity score of 0. 0 means complete control. This is where you score 0 every day for both itch and hives. And then another measure, and this is more, this is a 4-week recall. This is called a urticaria chronic test, where we ask patients these 4 questions. And this has more to do with quality of life. And for the disease to be well controlled, the score has to be 12 and greater. So 16 would be perfect score, but we accept 12 and greater as adequate control. And that is called the urticaria control test. So just to reiterate, this is done on a weekly basis. The urticaria activity score is done on a weekly basis, whereas this is a recall for the last 4 weeks. And then, it's important, I would encourage everyone to read this document. These are international guidelines. They were last updated in 2022. It's really evidence-based. It's a stepwise approach that talks not only about treatment, but also how to go about diagnosing urticaria. This was a consensus statement from 64 delegates representing 50 national and international societies from 31 countries. This includes India. There were representatives from the, from different centers. And it's important, I think, to be familiar with this document because this is really evidence-based. And so one of the things that we really follow, or we try to follow, is this concept. This is just like GINA, where there's a continuous feedback where you address, you evaluate, you address, you prescribe medications, but then you follow up. And based on the score, here's where the urticaria control test becomes very important. Based on the score, we either step up or step down, knowing that chronic urticaria is chronic, just like asthma is a chronic disease, average duration 2 to 5 years. So it's not just a one-time thing. Every 3 months, I like to see my patients back every 3 months. And then based on the score, if the score is 16, which means perfect control, then you can step down therapy. If it's 12 or above, between 12 and 15, then I just leave them where they're at. But if the score is less than 12, this is where you need to step up. And so this is important exercise to do every 3 months, especially if you're going to put someone on a biologic. And so how do you manage these patients? Well, it's a very simple algorithm. You start out with standard second generation. So these are non-sedating second generation H1 antihistamines. This would be things like fexofenadine, loratadine, desloratadine, cetirizine, levocetirizine. So whatever the standard dose is for whether it's a child, adolescent, or adult, you just give them standard dose and keep them on it. If that doesn't adequately control the hives, you increase up to 4 times the dose. Now, some people like to mix and match, which is fine, but you don't necessarily have to. You can just tell them quadruple whatever they're taking. Now, knowing that 50% of patients will not adequately respond, this is where biologics can play a role. So there are 2 options. You can either do omalizumab, which has been the gold standard for many, many years. And more recently, we have dupilumab, which is now approved. And then assuming that you don't improve on the biologic, then you go to cyclosporine. Now, it's important to recognize that the biologics are add-ons to antihistamine therapy. They're not a replacement. Just like in asthma, the biologic doesn't replace the standard of care. So standard of care is still 4 times second generation antihistamine. The biologic is just adding on to that. Keep in mind that biologics have no disease modifying properties. Okay, they do not modify the immune system. Once you stop the biologic, the disease will come back. And I'm going to show you, I'll show you examples. So hopefully all of you now are familiar with omalizumab. This has been around for many, many years. Here in the United States, it's been around for 23 years. It's an IgG1 humanized monoclonal antibody, but it does have certain parts from mouse, so it's not 100% humanized. Because of that, it does carry a small risk of anaphylaxis, 0.2%, and that is why we recommend that patients who are on omalizumab have access to epinephrine in case of anaphylaxis. What does omalizumab do? It binds serum IgE, regardless of specificity. Okay, so it's just binding serum IgE. It forms inert complexes. And so how does this translate into improvement in urticaria? Well, it turns out that these Fc epsilon R1 receptors, they are, on the surface of mast cells and basophils, they're in direct proportion to the concentration of IgE in the serum. So what omalizumab does, it binds free IgE in the serum. So now you have less free IgE. And because of that, you downregulate the number of Fc epsilon R1 receptors on your mast cells. And by doing so, you raise the threshold, means there's less chance of mast cell degranulation. So that is what we think is a primary mechanism of omalizumab in urticaria. And by the way, this is the same mechanism in other disease states like asthma as well. So basically, less Fc epsilon R1 is the end result, therefore less mast cell degranulation, therefore less release of mast cell mediators. Now, currently, at least in the United States and in many countries, the licensing authorities have approved omalizumab for patients 12 and older who don't respond to, appropriate doses of H1 antihistamine. It can be used safely in pregnant women. We have data for that. What we don't have official approval for is in patients under 12, but we certainly have a lot of anecdotal evidence. We know that omalizumab in other conditions like asthma, for example, has been approved down to age 6. For food allergies, it's been approved down to age 1. So there is a lot of safety data in children under 12. The conventional dose is 300 milligrams subcutaneous every 4 weeks. And first 3 doses are generally done in the office, and that is because of the small risk of anaphylaxis, assuming the patient does well, without any issues, without any complications, assuming that they don't have any risk factors for anaphylaxis, then we do allow, after the first 3 doses, we allow patients self-administer at home, provided that they have epinephrine auto-injector. Now, this dose, unlike other indications like asthma, chronic sinusitis, food allergies, for urticaria, the dose is independent of the serum IgE level. It's independent of body weight. Okay, so everyone gets the same dose. If you are not adequately controlled with a standard dose, which is 300 milligrams every 4 weeks, the guidelines do allow you to either shorten the intervals or increase the dose, up to 600 milligrams every 2 weeks. But that does mean that does imply a higher cost. So you have to be cautious about that. And again, patients who are on omalizumab really should have epinephrine in case of anaphylaxis, which is about 0.2%. Okay, so I mentioned this before. How does it work? Well, it lowers free serum IgE, therefore it downregulates Fc epsilon R1 on mast cells. It also, because it binds IgE, it will also bind directly if you have IgE antibodies, for example, IgE against TPO, IgE against interleukin-24, well, that immediately will bind. So that will actually cause a very fast onset of action versus, which is type 1 endotype. In type 2B endotype, the action will be a little bit slower because it's not directly acting on IgG antibodies. What it is doing is it is reducing the density of mast cell receptors, Fc epsilon R1 on mast cells. So that takes a little bit longer. So I'm going to share with you 3 studies. This was part of the regulatory process that got omalizumab approved for chronic spontaneous urticaria. First trial duration was 24 weeks. Second trial, 12 weeks. In these 2 trials, so these were both patients with chronic urticaria who were on standard dose H1 antihistamines who were still symptomatic. Primary endpoint here in both studies was looking at results at week 12. This third study, Glacial, is more what we do in the real world. These patients were on up to 4 times the dose of H1 antihistamine, plus a leukotriene modifier or an H2 blocker, or all 3. Okay, so yet we're still symptomatic. This was a 24-week study comparing 300 milligrams of omalizumab versus placebo. And again, the primary endpoint was looking at week 12. All right, so this is the first study. Again, remember this was a 24-week study, but the primary endpoint was looking at week 12. And so what you can see here is that basically the 2 arms that reached statistical significance, this is looking at the mean change in weekly itch score severity. So the greater the reduction, the less itch. And these were the doses. So omalizumab was given, here every 4 weeks. You can see that. And then omalizumab was stopped. And what you see, there are 2 things I want to point out, is that of the dosing regimens, only the 300 milligram and 150 milligram, okay, so 300 and 150 were statistically significant. The 75 milligrams did not achieve significance compared to placebo up here. Second observation is that it's really the 300 milligrams that really differentiates clearly, between placebo and active treatment. So 300 milligrams that is why it's generally the preferred dose, 300 milligrams. And you can see that it generally works fairly quickly. Within 2 weeks, there's a significant improvement. The treatment effect generally plateaus. And then once you stop the drug, you can see very quickly things revert back to normal. So omalizumab, although it works well, it works quickly. Unfortunately, once you stop the drug, things come back. Okay, so this was Asteria 1. Similar result in Asteria 2, which is a similar trial. These were patients who were refractory to standard dose H1 antihistamine therapy. And again, you see a relatively quick onset of action within 2 weeks. And then once you stop the drug, you can see that things revert back to normal. So definitely not a cure. It's really important to emphasize that. And then this was the last study. This is Glacial. Remember that these are patients who were not only on 4 times H1 antihistamine therapy, they were also on montelukast, H2 blockers. And again, you can see now there's only 2 arms, placebo plus omalizumab 300. And you can see within 2 weeks, rapid improvement. Once you stop the drug, unfortunately, things revert back. Now, one of the things that we look at in trials, is we look at, okay, well, what response do they have in terms of weekly itch score, weekly hive score? So if you look at actually all 3 trials, what you can tell the patient is you'll have about a 2/3 improvement in the itch score. Okay, so this is a reduction in itch score. You can see it's not 100%. So it's about 2/3 in terms of improvement in itch score, irrespective of what you're taking, whether you're just taking standard dose H1 antihistamine or if you're taking quadruple H1 antihistamine plus montelukast plus an H2 blocker. The magnitude of improvement is about the same, 2/3 for weekly itch and about 2/3 for weekly hives. And then if you combine the two, so again, it's about 2/3. So the reduction in urticaria activity score is about 2/3 in those who are on omalizumab. And these endpoints were measured at week 12. Okay, so this is important. It's not 100%. It's very important to emphasize that just because you add omalizumab doesn't mean that that your activity score will be 0. Now, that being said, there are people who do respond very well to omalizumab. And so this is another breakdown of the outcomes. This is by responders. Remember that urticaria activity score of 0 means complete control. Okay, so about 40% at week 12 who are on omalizumab 300 milligrams will have complete control of their hives, which is good, about 40%. And here you have anyone who has urticaria activity score of 6 or less, which means good control. Here, about 60% will achieve that. So 60% of patients on omalizumab by week 12 will have good control of their hives. 40% will have complete control. So that is the data on omalizumab. Are there predictors of response? Are there biomarkers that may predict response to therapy? Yes, there are certain biomarkers, but I want to highlight that none of them have been definitively validated. These are some of the biomarkers. It's a little bit, contradictory, so I don't want to spend too much time on this. But one of the things that, at least 2 of the biomarkers that I like to get before starting omalizumab is serum IgE level. We know that the higher the baseline serum IgE level, the more likely you will respond to omalizumab. If the baseline IgE level is low meaning less than 30, less than 20, then it is unlikely that omalizumab will work. Why do we know that? Well, because we know that omalizumab targets free IgE. So if you have a low baseline IgE level, then there's not much that omalizumab can target. We also know that when you have a low baseline IgE level, it also means that already there are fewer Fc epsilon R1 receptors on the mast cells. So again, it makes sense. This makes sense that if you have a low serum IgE level, probably will respond less to omalizumab. Okay, but this is not definitive. This is just speculation. The other thing I want to point out is if you have, this is another biomarker that I get. This is a little bit controversial, but I do get thyroid antibodies. Now this is here. These are IgG antibodies, so I get both TPO and antithyroglobulin antibodies. And we know that this is a predictive non-response. So if you have elevated TPO antibodies, elevated thyroglobulin antibodies, there is less likelihood that that your patient will respond to omalizumab. So these are the two biomarkers that I personally get. Maybe a third one, which I get, is just a CBC with differential. And we know that if you have less eosinophils, so less basophils, less eosinophils on your CBC, that is also associated with a less robust response to omalizumab. So anyways, I put these out here. None of these, however, have been validated consistently. So this is not something I would currently, please don't hang your hat on this. So here's my approach. So I do offer omalizumab first-line therapy. Initial dosing is 300 milligrams every 4 weeks. We know that 60% will have a meaningful reduction by week 12. 40%, in fact, will have complete response by week 12, which is good. We know that most patients will respond within 2 weeks, at least, first month. So first dose, vast majority will respond. And if they don't respond, some people do have a slower response, but at least, they'll respond within 3 doses. If after 3 doses, you don't have a good response, you can certainly increase the dose, which I do. I will increase from 300 milligrams to either 450 or 600, or I may increase the frequency. I may give 300 milligrams every 2 weeks. However, if after doing this, if there's still no response, then I stop. Some people just are not going to respond, so there's no point continuing treatment if after 3 doses, even at the higher dose, there's no response. Please stop therapy. On the flip side, how do you taper? Because patients, we know guidelines say you can step up and step down. So how do you taper off of Xolair? This is my approach. So once patients achieve complete control for about 2 or 3 months, then I start reducing the frequency. So I go from every 4 weeks to every 5 weeks, then every 6 weeks, then every 7 weeks, then every 8 weeks. If they're still well controlled on OMA every 8 weeks, then I discontinue. One of the good things about omalizumab is it has a high recapture rate, means you can restart at any time. So you don't develop, with OMA, you don't develop drug-associated antibodies that often. So you can stop, you can restart. And this is what I do. This is what I do. This is what I offer. All right, so now I want to switch gears and talk about dupilumab. This is, as you know, it is a humanized, so this is a fully humanized monoclonal antibody, which targets the IL-4 receptor alpha. And by doing so, by blocking this receptor here, it actually blocks signaling of both IL-4 and IL-13. Remember, IL-4 and IL-13, these are very important cytokines causing type 2 inflammation. And just like in asthma, just like in atopic dermatitis, just like in EoE, just like in nasal polyps, CSU, chronic urticaria, is a type 2 disease. How does it work? Well, we know that IL-4 is critical for class switching. So if you block IL-4, you basically reduce production of IgE, but also IgG to a certain extent. Okay, so that's one of the ways that dupilumab works in urticaria. We also know that IL-13 actually increases the expression of Fc epsilon R1 on mast cells. So by blocking IL-13, you actually reduce the number of receptors, Fc epsilon R1 receptors in your mast cells. We also know that IL-13 is involved in itch. It actually makes you more itchy. IL-13 activates IL-31, which is also involved in itch. And we also know that both IL-4 and IL-13 also has an effect on other cells like basophils, eosinophils, B cells, T cells. So these cytokines definitely operate in chronic urticaria. And so the question is, what happens if you block IL-4, IL-13? What happens to your hives? What happens to your itch? And just recently, a few months ago, dupilumab was approved in the United States for chronic urticaria, again, in patients 12 years and older who are symptomatic despite H1 antihistamine therapy. Dupilumab is, the dosing is weight-based. You have a loading dose, and then you have a maintenance dose. Unlike omozumab, this, however, is given every 2 weeks. So instead of giving one injection per month, patients get 2 injections per month. However, because it is fully humanized antibody, there is no risk for anaphylaxis. So patients do not need epinephrine, and they do not need to dose in the office initially. They can dose directly at home. And here's the dosing based on the patient's weight. There are 2 studies which I want to focus on that looked at the efficacy and safety of dupilumab in urticaria. So these were 2 replicate studies where you had patients who were naive to omozumab, who had chronic hives for 6 months, not getting better in spite of H1 antihistamine therapy. We're getting up to 4 times the standard dose. We're still symptomatic. And so they were randomized to either placebo or dupilumab. The one thing I want to point out here is that the endpoints were measured at 24 weeks, not at 12 weeks. And so here's an example of Cupid A. What you're seeing here is a reduction in the urticaria activity score, UAS7. This is a reduction in the weekly itch score, and this is a reduction in the weekly hive score. What you're seeing at the top is placebo. What you're seeing at the bottom is dupilumab. And one thing that you do notice is that unlike omozumab, where you see a very rapid response within 2-3 weeks, here you see a much more gradual response. In fact, a maximum efficacy doesn't occur until 24 weeks. So, for all the endpoints, which means that dupilumab, although it works, is going to take a lot longer to work, up to 24 weeks. So you do have to caution your patients to please remain patient. In terms of, efficacy, here you can see basically the reduction. This is at 24 weeks. This is placebo, and this is dupilumab. You see about 8.5 point reduction compared to placebo in the urticaria activity score, 4.2 reduction in the weekly itch score, and about 4.4 reduction in the weekly hive score. How does that translate clinically? So this would be, what's the responder analysis? So about 32%. So with omozumab, it was about 40%. Here, about 32%, about a third had achieved a UAS7 score of 0 at week 24, means absolutely no itch, absolutely no hives. And almost 50% at week 24 had at least a good level of control. They had a UAS7 score of 6 or less. So results are a little bit less robust than omozumab. Also, it takes a little bit longer. Here, this was measured at 24 weeks versus 12 weeks. That being said, these improvements, were observed regardless of baseline serum IgE, regardless of BMI. And so where would I use dupilumab compared to omozumab? Well, in cases where the baseline serum IgE is very low, I may use it because this may be better fit. Or if a patient has other type 2 comorbidities, if a patient has urticaria plus atopic dermatitis or urticaria plus asthma or EOE or chronic sinusitis with nasal polyps, in this case, dupilumab can be preferred as it will treat other comorbidities as well. So food for thought, take-home points. Remember, chronic urticaria is relatively common, about 1%. This is where you have hives or angioedema or both for about 6 weeks or more. Remember that most patients with chronic urticaria experience poor quality of life. It is a persistent disease, 2 to 5 years duration for most patients. Most of the time, you're not going to find a specific cause. And about half the time, patients will be inadequately controlled in spite of H1 antihistamine therapy 4 times the dose. And so now you have 2 biologics formally approved that can be potentially beneficial in these patients. Both selectively target inflammatory pathways, therefore they're cortical sparing. That's one thing I didn't mention. So, there are side effects of corticosteroids. So this allows you to treat these patients without having to use corticosteroids. Drawback currently that they are both cost prohibitive, but this may improve in the future. So I will pause there. Thank you very much. And if we have time, I'll be happy to take questions.
Thank you so much, sir, for such an enlightening talk from pathophysiology to algorithms to scoring and to the biologics. Yeah, everything was very enlightening and very clear to all of us. I'll just see if we have some question. We have one question from Dr. Neeraj Gupta. He has asked, whenever we speak about the use of omalizumab in asthma, there is a need for total IG, whereas in chronic urticaria and food allergies, it is not required. Why?
Well, for food allergy, yes, the food allergy you do need. For food allergy, it is based on the dosing is based on weight as well as IgE level. But for CSU, it is not based on weight or serum IgE level. That being said, I will still get IG level just because of
Your talk
IgE may be a biomarker. So low IgE means
predictive.
Having a low IG level from baseline means that you probably will have a less robust response to omalizumab.
Okay. So it does have some value in prognostication and seeing the response.
I think so. And IG level is relatively inexpensive, so I would just get it.
Thank you, sir. Thank you so much. I think we don't have, so no, we don't have any other question. So just one question, like suppose like we work in resource constrained setting. So if not biology, if not omalizumab, what would be the thing which we should go for? Like?
Yeah, so this is where the guidelines are very clear. So if this is not feasible, if omalizumab is not feasible, if dupilumab is not feasible, then I would choose cyclosporin. The analogy of cyclosporin would be tacrolimus, and there's very good data on cyclosporin. It is also corticosteroid sparing. Cyclosporin works relatively quickly. It has almost equal action in terms of efficacy as corticosteroids, but without the side effects. And one of the things that cyclosporin, in addition to its efficacy and its relative safety, is it can actually induce remission in about 2/3 of patients. So unlike biologics, which have zero disease-modifying properties, cyclosporin potentially can remit the disease. So that's another advantage of cyclosporin over the biologics.
Thank you. Thank you, sir. Thanks a lot. So I think so I will move to our next talk now, which is again a chronic relapsing skin condition. And again, as it is chronic urticaria, it is also a very distressing condition. The first manifestation of the atopic march, and as it occurs in small age, infancy, young children, again, it gives a lot of problem to all of us. And for enlightening on this topic, I welcome Dr. Shrabani Johha ma'am, and she's a senior dermatologist at Apollo Multispecialty Hospital, Calcutta, and she has an extensive experience in treatment of allergic disorders in children. A warm welcome to you, ma'am. And ma'am would be talking about biologicals in atopic dermatitis, role of dupilumab, and other agents. Thank you, ma'am. A warm welcome to you.
Thank you, Sonia. Just give me a moment. Just give me a moment.
Yes, ma'am.
Oh dear.
Yes, started screen sharing, but we cannot see the screen, ma'am, yet.
Yeah, That's what I'm trying. Oh dear. Can you just give me a moment? I will just go out and. Oh my God. What's happening? I will just join again. Just give me a second. I'm very sorry.
Good evening, sir.
Yes, good evening, Sonia. How are you?
I'm good, sir.
Okay.
I think ma'am will join. She was not able to share the screen. We'll just see. If it's difficult, probably then we'll request her that you can do first. Let me wait. Let's wait for some time.
Dr. Sonia, there is a question for Dr. Vinay. Can you please take from the chat box?
Okay. Is it there? Okay, now I can see. Yeah. So, Vinay sir, there's again a question for you. What age group is safe and any side effect in your experience?
Yeah. So with omalizumab, we have 24, 23 years of experience with omalizumab. It definitely is safe. We know that omalizumab can be used as young as age 1 for food allergies. Now, for chronic urticaria, the regulatory approval is only for 12 years and older. But as far as safety, we know that it can be safely used in children as young as age 1. The only concern about omalizumab is there is a 0.2% risk of anaphylaxis, and therefore the first 3 doses must be done in the office. Typically, after the first dose, we observe the patient for 2 hours. So that is the one barrier, I think, especially in a country where you don't have epinephrine auto-injector. We have to give pre-filled epinephrine in a syringe, and we put in a spectral case. That may be challenging. But aside from that, omalizumab we have extensive safety study, including pregnancy. There's a very large trial done in pregnant women, essentially no side effects. With dupilumab, we know that also, is in fact, for dupilumab, it is approved on age 6 months in atopic dermatitis. So not for chronic urticaria, but for atopic dermatitis, we can use it as early as age 6 months. The benefit of dupilumab is there is no requirement for epinephrine. So patients can directly take it, at home. The one caution with dupilumab is it can raise the eosinophil level. So in a country like India, where you have a lot of parasitic infections, and if you have a high baseline eosinophil level, then that can push the eosinophil level even higher. The other concern you may have with dupilumab is dupilumab blocks trafficking of eosinophils from the blood compartment into the tissue. So if you have a child who has a parasitic infection, definitely tell the parents temporarily stop the dupilumab until you treat the parasitic infection, then resume it.
Ma'am is joined back.
Hello,
Shabini
good
ma'am.
evening, everyone. Can I take a quick question till ma'am is joining?
Bol, ma. Question.
Okay, relax, mom. You need to breathe.
Bol.
I'll ask one question to Dr. Vinay. Is that okay?
Tell them that you have technical
Yeah,
difficulties.
ma'am. Yeah, ma'am, you can take.
Yeah. So I was wondering, Dr. Vinay, very
Mhm.
clearly we know if there is anti-TPO antibodies or TGO antibodies, omalizumab doesn't work. And we should be giving cyclosporin, it works really well. The issue here is cyclosporin can have a lot of, bone marrow depression or can cause severe infection, unfortunately, if it causes a lot of suppression. Would we be safe in the court of law if we skip omalizumab and directly go to cyclosporin? Or are we
Mhm.
supposed to follow that,
Yeah,
twice antihistamine, 4 times, then omalizumab, then cyclosporin? Or
yeah.
is it okay?
No, it's the guidelines, the
Cyclosporin has so much
guidelines.
side effects.
Yeah. So, well, first of all, just to clarify, if you look at what is safer, cyclosporin or prednisone, cyclosporin is actually safer. We sometimes forget, we sometimes forget that prednisone also is immunosuppressant. It can, if you have an active infection, it can make the infection worse. It has a lot of side effects in children, especially growing children. It can stunt their growth. It can cause lots of, ravages. And certainly long-term diabetes, hypertension, hyperlipidemia, thinning of the skin, early cataracts, osteopenia, osteoporosis. So let's not think that prednisone is a safe drug. Head-to-head, cyclosporin is actually much safer. Yes, there are precautions. You monitor blood pressure, you monitor kidney function. The one good thing about cyclosporin is if anytime you see a bump in blood pressure or creatinine, you can always stop cyclosporin. It generally, the side effects go away. So I've not personally seen any permanent damage from cyclosporin. Now, to your question, do you have to cycle through biologics? No, the guidelines are, they're clear. If it's not available, certainly dupilumab right now in India is not available, widespread. Umozumab is available, but it's costly. So you don't have to cycle through it. You can go through directly to cyclosporin, which is what I do. Even here in the United States, there are people who don't want to go cycle through biologics. So it's perfectly reasonable and it is part of the guidelines. The other thing I want to also highlight is that the doses that we use are lower. We use 3 milligrams per kilo per day, which is often lower than what we would use in, let's say, in a transplant patient. So,
Sora, ma'am.
I think it's important to always weigh the pros and cons and keep in mind that prednisone, which is often overused, prednisone itself can be potentially dangerous. So keep that in mind.
Thank you for that. Thank you for clearing.
So I think Dr. Shrabani is having some problem joining. Shall we start with, can we take Dr. Saibal's session then? Sir, you'll be taking the set. Can we do that, Dr. Neeraj?
Yes, so I think we should start with Dr. Saibal. And the next session, Serge will be joining from France. So we should give him at 9:30. So we will see if Dr. Joha can do the session at the last. No problem. So let us start with Dr. Saibal.
Okay,
Okay.
thank you.
So till Dr. Shrabani joins, we'll be welcoming one of our very esteemed speaker, our own Dr. Saibal Moitra, sir. Dr. Saibal Moitra is an allergist, immunologist, and pulmonologist. And he's a current chief of Department of Allergy and Immunology at Apollo Genesis Hospital, Kolkata. He's an avid researcher. We all know that. He's a true academician and an excellent teacher. He has many publications, international and national, and he'll be taking us to a journey of what lies ahead, the biologicals which are now coming in, anti-TSLP like tezepelumab, anti-IL-3, and the combination therapies, as these are the biologics which can be used despite of the phenotype limitations, despite of some the biomarker limitations. And a warm welcome to you, sir. Please take over the stage.
Thank you so much, Sonia. Good evening to all. It was really nice, Vinay, to see you. And thank you, Neeraj, for organizing this superb webinars under the banner of IAP Pediatric Allergy and Applied Immunology chapter. So in the series of the biologic talk, so Neeraj entrusted upon me to talk about something which is still, I would say, a bit futuristic. Okay, so we have heard excellent talks about the biologics in severe asthma, in urticaria. We'll be hearing about atopic dermatitis and all those which is there available in the market. But if you see the growth of the biologics, it's growing pretty fast. And so every year or so, we come across as new biologics targeting newer molecules. And so we presume that the future is quite green as far as the biologics is concerned. So I'll be talking about mainly the pipeline molecules and the combination therapies and at what stage they are. And my talk would be mainly concentrated on the airway allergy, that is your severe asthma. So I have nothing to declare in relation to this talk in today's evening. So let us come to this very interesting picture, which I've got from this article published only last month in Allergy. So we can see that we all know that allergic disorders are increasing. So there's approximately 1 billion patients all over the world who are suffering from allergic disorders, and it is a global health problem. Now, why it's increasing? So we know that there are multiple factors to it. Now we talk about the epithelial dysregulation and hypothesis, where the main insult is from the outside. And we talk about that the exposed triggers, that is the exposomes, which bring about the changes. And this causes the dysregulation in the interface between our body and the environment. So this is very much important. So we said that whatever comes, at first it comes in contact with the epithelial membrane. So it could be a bacterial proteins like egg, or it could be some pattern and this pattern has certain molecular patterns. It could be viruses, allergens, pollutants, double-stranded DNAs, and things like that. So all of this impinges upon the epithelial membrane and brings about some epithelial barrier disruption. Now, this activation of the epithelium, it causes the release of the alarm signals, and we typically talk about the thymic stromal lymphopoietin, TSLP, IL-33, and IL-25. And these are pretty upstream molecules in the inflammatory cascade, and then they bring about the typical phenotypic inflammation downstream. So my talk would be mainly concentrating on this TSLP, IL-33, and IL-25 because we have some good data regarding these molecules. Though as we understand that there are further downstream signaling molecules which are actually blocked by various biologicals, and I will just quickly go through that in the next couple of minutes. So let us understand that why we are talking about the alarmins so much. So we know that all these allergens or the bacterial like lipopolysaccharides, the flagellins, or the viral nucleic acids, they all will impinge on the epithelium. And this epithelium, depending upon that how it interacts with the epithelium, it brings about that specific activation of the epithelial cells and release of the signal molecules. So maybe if we talk about the dust mite, and we talk about the proteases in the dust mite, like the DARF2 or the DARP2, which actually activates the protease activating receptor PR2, or maybe the DARP2, it actually interacts with the toll-like receptor TLR4. And maybe that there are other PRRs like the dectin-1 and also the TLR5, along with the C-type dectin receptors, which are the cytosolic receptors. So this leads to the release of this IL-33, the TSLP, and the IL-25. And these three molecules, they actually impact not only the cells of the innate immune system, but cells of the adaptive immune system as well. So if we talk about the cells of the innate immune systems, we know that all these three alarmins, they impact upon the various components in the innate immune system, which we talk about. One is the type 2 innate lymphoid cells. Then we have the conventional or the myeloid dendritic cells. Then we have the macrophages. We have the alternatively activated the macrophages, which we call the M2 macrophages. And also, it has an impact on the eosinophils, the neutrophils, which are we call the main and worker of the innate immune system. So we know that this causes the activation of this entire this gamut of the cells which are there and comprises the important component of the innate system. So if we see, so one by one, we'll just slowly try to unravel what is happening there. So if we see that the TSLP, of which we have the maximum amount of the data, and this was the first is the alarmin molecule against which a biological was generated among the other alarmin molecules. So what it causes is that if you see that it not only has an impact on all these cells, also the innate immunity, but its cellular targets are also the cells, the T cells and the B cells. And this leads on to the release of majority of the type 2 cytokines, when we call about dial 4, 5, 9, 13, the signature T2 cytokines, and cause the B cells to release the IgE. At the same time, this causes the release of various chemokine molecules also from the cells of the innate immune system, which causes is the homing in of the various other cells like the eosinophils, namely we call say eosinophils and also the monocytes. It is the blood derived, it is the monocytes derived from the blood and also the neutrophils. These are the CCL1, CCL11, but very importantly, CCL17, 18, 19, and the 22, as well as the TNF alpha. So all these leads on to the inflammation in the airways, and not only the initiation of the inflammation, but also the maintenance of the inflammation in the airways, which leads on to the activation of the smooth muscles, and this causes the airway remodeling. At the same time, there's the maintenance of the inflammation in the airways brings about what we see as the airway responsiveness. The clinical sequelae being the more frequent exacerbations, the reduced quality of life, and the worsening of asthma symptoms of poor lung function. So as you will see that all the archetypal studies or the major studies is which actually wanted to see the effect of these monoclonal antibodies in them. The primary endpoints were mainly these, that is the reduction in the annualized asthma exacerbation rates, which was the main, or the severe exacerbation, which was the main primary endpoint. Along with that, the quality of life, the control, the asthma control, and also the FEV1, which is important in these things. So what we know about, so this is just a small diagram taken from the skin, from what is in the skin, but also similarly this happens and in the airways. So we know that apart from this TSLP, IL-25 and the IL-33, and this we also know that we have the other molecules which is important, and of this the one important is the IL-31. And we have these newer molecules, that is a nemolizumab, which actually blocks the IL-31. And this IL-31 is important for the itch-scratch cycle, maintaining the itch-scratch cycle and irritation of the nerve endings. So let us come back to the main topic of the day, that is the alarmin blockage. So if you see that in the development and of this alarmin blockade monoclonal antibodies, so this is basically the main cell. It is the Th2 cells, and from the epithelium is release of the TSLP and the IL-33. Now the TSLP and the IL-33, they are very important in the initiation of the inflammatory response, and they causes as the naive T cell in the presence of the type 2 cytokines to take up a Th2 phenotype. And it is not only that, it also causes as the maturation and the activation of the myeloid dendritic cells. And with the maturation and activation of the myeloid dendritic cells, it causes the expression of the various molecules on its surface. When we talk about the expression of various molecules, like the antigen-presenting MHC class II molecules, and the various co-stimulatory molecules that we talk about, like the CD80, CD86, CD83, and very, very important is this OX40 ligand. This OX40 ligand, it interacts with the OX40 molecule on the Th2, and this causes the naive Th naive cell to achieve a Th2 phenotype and the release of the various Th2 cytokines. Not only this, this amount of this alarmins causes the increased expression of this alarmin receptors on all the cells of the innate immune system, namely the dendritic cells. So the TSLP receptor is upregulated. The IL-33 receptor, that is the ST2, is upregulated. IL-25 receptor, that is the IL-17 receptor alpha and the beta, both are upregulated in all these cells. And then when it comes to Th2 activation, which causes release of the IL-4, 5, 13, and this IL-4 is needed for the B cell to cause it to form plasma cell and produce the IgE for the class switch recombination. And IL-5, which is needed for the homing, activation, and survival of the eosinophils. IL-13 is basically the IL-4, 413 pathway, and it is needed for basically for the mucus hypersecretions. And at the same time, when we talk about the IL-31, it is needed for, it causes the itch scratch cycle in the skin. So if we take a much close look at the TSLP, so let us start with the TSLP. So you see that there is this bacteria, these allergens, and these viruses, and it impacts on the epithelial airway epithelium and cause activation and release of the thymic stromal lymphopoietin. Now this TSLP, then actually first it causes as the activation of the type 2 innate lymphoid cells. And you can see that the TSLP receptor are there on the type 2 innate lymphoid cells. Then it causes the macrophages to attain a M2 phenotype. And this alternatively activated macrophage in the presence of the other type 2 cytokines is actually, it causes the mediation of the type 2 inflammation. This ILC2, it produces lots of IL-5 and the IL-13. These are very important and type 2 cytokines. And this produces 100 times more of the IL-5 and IL-13 than a Th2 cells. So that means this entire area is actually flooded with the interleukin-5 and the interleukin-13. At the same time, this TSLP, it acts on the dendritic cells. And I have said that it causes the activation of the myeloid dendritic cells or the conventional dendritic cells. And it is causing increase in the MHC class II molecule and other co-stimulatory molecules like CD40, CD80, 86, CD83, CD-LAMP, CD54, and all these molecules. And this CD40 ligand, it interacts with the CD40, which is upregulated under the milieu of the L5, L13, and causes as this naive T cell to achieve a Th2 phenotype. And there is also this clonal proliferation of this Th2 and the differentiation of these cells. At the same time, there's the T follicular helper type 2 cells. In the presence of the interleukin-4, it causes the proliferation of the B cells and also the B cells to achieve a phenotype where it secretes IgE. So the somatic hypermutation and the class switch recombination and of the B cell in the germinal center and increased release of the IgE from the long-lived plasma cells. At the same time, you can see that all these chemokines, that is the CCL17, 18, 19, 22 from the activated macrophages, and also from the activated dendritic cells, these are important to actually homing for the various inflammatory cells and bring the other cells that act, the other T lymphocytes, the eosinophils, and also later on the neutrophils else to the site of this the allergen exposure, and this maintaining an environment of the inflammation in the airways and which leads on to the development of the features which we see in asthma. So we see that the TSLP acts much more upstream, and it has a pleiotropic effect affecting multiple cells of both the innate and the adaptive immune system. So when we talk about this, the TSLP, this has an impact on the fibroblasts, causing the fibroblast deactivation because of the activation of the entire cascade of the events that we have just stated. And also there is a smooth muscle cell activation, and because it also has a TSLP receptor, and it causes the release of the various collagen factors and leads on to the airway remodeling. At the same time, the release of the IL-6, interleukin 8, and CCL11, all it causes the increase or more or amplification of the inflammatory cascade in the entire milieu. And not only that, there is migration of the actin proliferation and polymerization and the cellular polarization of the smooth muscles, which is entirely brought about by the TSLP. Now, if we go into the interleukin 33 is one of the earliest alarmin to be released from the airway epithelial cells. And this is one thing is very, very important at interleukin 33, that it causes the activation and of increased survival additional activation of the eosinophils along with interleukin 4. And this eosinophil, there is increased formation of the eosinophils from the bone marrow, from the eosinophil progenitor, which comes from the common myeloid progenitor cells, and they come into the tissues. Not only that, it also causes the mast cell to release the interleukin 13 and also the activation of the basophils. And it binds to the various interleukin 33 receptors, which are there on the endothelial cells, which are there on all the cells, which are there on the fibroblasts. And there is release of all these is T2 cytokines, the interleukin 4, 5, 9, 13, the histamine, this addition and priming of the eotaxin-induced migration of the basophils into the site. So this is quite important that it causes the initial amplification of and priming of the inflammation. When we come to the interleukin 25, interleukin 25, it acts more as an add-on or an inflammatory increasing and priming and increasing cytokine, and has its effects on the eosinophils, the basophils, the fibroblasts, the smooth muscles, and the endothelial cells. So we can see that all these three alarm signals or the alarmins, cytokines, it initiates the inflammatory process as in the airways or any tissues which is there in the interface with the environment, and starts the T2 inflammatory process. So the important drug which blocked the TSLP is the tezepelumab. We'll be just talking about it. Now, we have lots of evidences on the tezepelumab, and we know that the pathway trial and the navigator trial, which is the landmark trial for the tezepelumab, it showed that after allergen inhalation challenge, that the anti-TSLP, it reduced the eosinophils in the airways, it reduced the nitric oxide, the axial nitric oxide. So these are two important biomarker of the T2 inflammation in the airways. It caused the airway hyperresponsiveness to be reduced, and also the early asthma response and the late asthma response were substantially abrogated with the use of the tezepelumab. Now, then from the IL-33, there's the IL-33 inhibiting a monoclonal antibody, that is the itepekimab. It also showed the similar effects as was shown by the tezepelumab. But the tezepelumab, one of the interesting thing of the tezepelumab was that though the tezepelumab was used in the T2 high or the high eosinophil patients with the high eosinophils, but it also showed a robust effect and on those with the lower eosinophils, because we see that this is acting quite high up. And we have seen that it causes the release of the various chemokines, which causes as the accumulation of the neutrophils as well. So this is of, as Sonia was saying, that this is one of the beauty of this tezepelumab, that is it works well on both with a low eosinophil and those with a high eosinophil as well. But the itepekimab, it mainly worked but with a higher eosinophils, because we have seen that it has an important and impact on the eosinophil migration. Then we have this is the astegolimab. This astegolimab is one of monoclonal antibodies which blocks the ST2. And ST2 is the main and receptor for the IL-33. And so by blocking the ST2, it blocks the IL-33 ST2 axis. And this ST2 receptor, though it's present as a soluble form also, but soluble ST2 acts as a decoy receptor, rather like means eating up the monoclonal antibodies, and though it does not have any effect further. But the ST2, membrane-bound ST2, which is present in all, that is the eosinophils, the mast cells, the basophils, the endothelium, the fibroblasts, it causes the abrogation of the IL-33 ST2 pathway, leading to the decrease in the annualized asthma exacerbation rates, leading to the decrease in the eosinophils, and also improving in the quality of life. So the studies so far that we have got from these two molecules, that is, they were statistically significant improvement in the asthma control and the asthma quality of life, but that was not very meaningful clinical important difference. So mainly it was the exacerbation rates which was reduced. And in case of the IL-25, this brodalumab was the IL-25 antagonist, that is mainly blocking the IL-25. But this as monoclonal antibodies has not provided very interesting or very good or gratifying responses, because we have seen that IL-25, it more acts as an amplifier of all the inflammation in the airways. So this was a study which was published like a few years back, and this was the astegolimab efficacy and safety in adults and severe asthma, including patients with a low eosinophils. And the primary endpoint again was the annualized asthma exacerbation rates, and which was actually seen to be working well in those with both the high and the low eosinophils, as like the tezepelumab. So when we come to the IACI Biologicals guideline, so it said that it depends upon the three pillars. One is, first we have to do the phenotypic traits, like the exacerbations, the lung function, the fixed airway obstruction, and the comorbidity, the type 2 T2 comorbidities, or the biomarkers, the eosinophils, pheno, and total and specific IgE, and the outcomes. Obviously, what we want to look into, that is the whether reduction of OCS, ICS reduction, exacerbation reduction, asthma control, comorbidities, quality of life, and the safety. So all this leads to that we decide upon that which biological is good, and then we decide upon the biological. Start the therapy, we assess the response, and if it is suboptimal response, we reassess the inflammation by the airway hyperresponsiveness, induced sputum, or a surrogate marker, that is the blood eosinophils. And we see if the neutrophilic inflammation, we tend to stop the usual biologicals acting on the T2 pathway. But tezepelumab we have seen is good for all, but it is suboptimal response, we have to stop that. If it is a persistent eosinophilic inflammation, then we have to check the adherence to the overall treatment plan, and then we see the inadequate dosing, then development of the neutralizing antibodies, and we will switch to the other biologicals. So interestingly, so this is a multidisciplinary structured approach, we optimize disease labeling, we choose the biological agents, set the targets, monitor. If targets are met, we continue. Targets are not met, we consider switching. But now recently something new is evolving, that is combining the monoclonal antibodies. So there were a few case reports. There's from the Mayo College. That is this one of the study which was published. It said that yes, the combination of omalizumab with mepolizumab, omalizumab with dupilumab, omalizumab with benra, or this mepo with dupi, and all those things, and they have shown to be promising results. Another is the combination of the tezepelumab and omalizumab for severe persistent asthma, and this also has shown to be promising in this. So first of all, it's very this is taken from a paper 3 years back. It said that whether we are combining the biologicals for the single disease entity, or we are combining the biologicals for a severe asthma with other T2 comorbidities, which is more common. So like if we choose the biologic omalizumab for severe asthma or chronic spontaneous urticaria or chronic rhinosinusitis with nasal polyposis, then we may have combined another biologic agent like MEPO for another for asthma, EGPA or hyperosmotic syndrome, or Benra for severe eosinophilic asthma, or dupilumab for asthma, or ocitriptan asthma, or atopic dermatitis, or the eosinophilic esophagitis. Similarly, for MEPO also, we can do it for this one of these as conditions, and we add another for another T2 comorbidities. And similarly, we see for Resli, for Benra, for Dupi, and for the tezepelumab as well. So all these combinations, definitely it in some way or the other, it proves to be safe, and it proves to be useful. Well, we do not have very long and very large evidences. Now we have some study trials coming from the Germany, which will throw more light on this. So if we conclude that the new biologic agents targeting upstream molecules, which we just talked about out in the TSLP, IL-33, IL-25, holds a lot of promise for the future treatment options. And there's a lack of enough data standing today, that is this date in July 2025, regarding combining biologics for severe asthma and the type 2 comorbidities. But several case reports and series show positive outcomes. And maybe in the next 1 or 2 years, we'll be having the guidelines for combination of the monoclonal antibodies, because some of the studies show that individual MABs are equally efficacious than combining the MABs. So there is a concept of switching to another MABs. And there's another concept of the cycling treatment. That is, we give a one combination and then we cycle to another combination, which is coming in which may be of helpful in fewer on case-to-case basis. So that's all for this talk, and I hope that I was able to throw some light on this topic, and I'll be glad to take some questions if they're there.
Thank you, sir, for such a lucid presentation, and from the role of these biomarkers in the disease to how we use it and how they are going to benefit in the difficult to treat asthma. That was a very enlightening talk, and thanks a lot for enlightening us. And yeah, this is the future. As if whatever we understand now, this is the future, and we all have to learn slowly about it. And thanks a lot. So I just see something. I cannot see any question as of now. So thank you. I think I'll just so Dr. Neeraj, shall we take Shrabani ma'am's?
Yes. We will try with Dr. Sabhan. Yes.
Even Dr. Saji has joined, so Dr. Shrabani would be speaking first. Yeah. Okay. So, ma'am, yeah, your screen is now seen.
Yeah, very sorry about this technical glitch. Can you hear me?
Yeah, we can, ma'am. We can hear you, and we can see your slides as well. Only you have to make them slideshow, and then you're good to go.
Yeah. Okay, a very good evening to you. Now, today I'm going to talk about biologics and atopic dermatitis. Am I audible?
Yes.
Yeah. So atopic dermatitis is a chronic disease, logist, and it really affects the quality of life in a big way. Now, with the advent of this pathology over last decade in atopic dermatitis, the therapeutic landscape has actually seen a huge shift. The emergence of new biologics and the targeted therapies have actually showing remarkable promise in managing atopic dermatitis. So how do we define atopy? It is a chronic and relapsing inflammatory disease characterized by extreme pruritus and eczematous dermatitis, and is often seen in families with atopic diseases. Generally, the infants and children are affected, but it can continue to adulthood or it can start de novo in adults. In a study in 2010, 230 million worldwide people were estimated to have this eczema. In Western world, the incidence is about 20% children and 10% adults are affected, whereas in our country, it was estimated 13% of children and 5% of adults are affected with atopic dermatitis. Unfortunately, the incidence varies from various parts of India, and we don't have any pan-Indian studies to show the real data. But what we know, the data is definite from the from the studies. We know that the data incidence of atopy is definitely increasing, and this is with sync with this that we know that eczema increases with low humidity, low ultraviolet exposure, more urbanization, and it actually supports the theory of hygiene hypothesis, which says that increased exposure to allergen or the microbiomes during childhood or infancy actually helps the innate immunity to develop. Also, we have seen many of our patients, they resist treatment of atopic eczema because they think that if they treat the eczema, they can develop asthma. It is important again to emphasize that this is a spectrum of disease and not necessarily it's a linear progression or all of them will have all the diseases. But what it shows is the interconnectedness of the condition and the associations between them. So we need to reassure that they're separate diseases and we need to treat them. So what leads to this atopic dermatitis? We have a barrier dysfunction, we have immunologic abnormalities, and there are certain aggravating factors which leads to atopic dermatitis. Now let's look into the pathogenesis. We know that there is a disrupted epidermal barrier in atopic dermatitis. There's lack of sphingolipids, and so all this the transepidermal water loss is more. So that actually encourages penetration of the allergens and irritants and also other environmental factors in presence of genetic predisposition initiates this immune dysregulation. And also there is alteration of skin microbiomes. We know that 90% of these atopic dermatitis patients can have increased staphylococcal colonization. So how do we diagnose atopic dermatitis? Traditionally, Hanifen and Rajka criteria, which was laid in 1980, it has 4 major criteria and 23 minor criteria, but practically it becomes impossible, sitting in the clinic. So this American Association of Dermatologists has come up with these criteria which have essential features, important features, and there are certain associated features which can be looked into. Now, atopic dermatitis in childhood as well as in adulthood. In infancy, it can be extreme. It usually affects the face, sparing the perioral areas. There can be a lot of eczematization, and not only the child suffers, it is very difficult to make the parents understand that there's no cure for it, and that we have to manage this symptomatically. That becomes very difficult at times, and because they have an increased surface, body surface area, you can't use too much of steroids for these patients as well. So it becomes really challenging. Then we have this atopic dermatitis in childhood, where the usual features are pityriasis alba, perioral dermatitis, and usually they present with this flexural eczema. Sometimes they can also have extensive diseases which bothers them, And in chronic cases, there is lichenification, thickening of the skin, and these lesions are extremely itchy. The child is at times irritable. They lose their school days, and it's a social stigma. And of course, the parental anxiety that is very difficult to address. And we don't have a lot of options other than topicals and systemic treatments. They are quite toxic. So really, it is a difficult situation. And in adults, the lesions become more chronic. They can have acute exacerbations, but usually they present with this prurigo, lichenified lesions. Sometimes this prurigo nodularis, this is a very tough condition to treat. Now, atopic dermatitis in adult has recently been described. Previously, we used to think it is the continuation of the childhood eczema, but now we know in adult de novo, the lesion can appear. And in an Indian study, it has shown that these adult onset atopic dermatitis have increased incidence of this head neck eczema, high serum Ig. They do suffer long duration of eczema, and they are associated with smoking. So how do we determine the severity of eczema? We have several indexes like eczema area and severity index, scored investigator global assessment score, but all these are mainly important for clinical trial purposes. In a day-to-day practice, we usually look whether the disease is mild, moderate, or severe, whether it is affecting the child's sleep, how bad is the pruritus, whether there is cooling is affected, and whether the quality of life is affected. And again, when we consider treatment, we have to take into consideration the associated comorbid features like associated cardiometabolic diseases, sleep disturbances, association with depression, anxiety, other atopic comorbidities. All these things will help us to determine what treatment we will take. Now, the Joint Task Force for this atopic dermatitis have laid down this guideline that we must educate the patient and make them understand regarding the chronic nature of the disease, importance of treatment adherence, the importance of skin care. Now, the cornerstone for treatment of atopic dermatitis for so long has been topical steroids. And when the topical steroids are inadequate, we add this topical calcineurin inhibitors. But now also we have other molecules like crisaborole, which is a phosphodiester inhibitor, and ruxolitinib is a topical JAK inhibitor. Now, when this topical fails, sometimes we need to add systemic treatment, and the recommendation is biologic therapy with dupilumab or systemic immunosuppressive agents. And of course, whenever needed, we need to treat the bacterial infection, viral infections, because we know that atopic eczema can sometimes deteriorate, and it can be associated with staphylococcal infection or with herpes simplex virus infection, which is also known as Kaposi's varicella eruption. Now, because topical steroid is the cornerstone of the treatment, we know these topical steroids can get absorbed and also give a lot of side effects to the child. So it is important that we treat the patient accordingly, and sometimes we need to give systemic therapy. Now, again, this is a recommendation by the task force. The first line treatment they've advocated is dupilumab and then tralokinumab. Phototherapy is always an adjuvant treatment, and recently these JAK inhibitors have also been advocated. So why do we need these biologics? When the disease is moderate to severe and not responding to existing treatment, when the duration of disease is prolonged and affecting the quality of life, when other systemic agents are contraindicated, and also we can use this treatment when there's other associated comorbidities like asthma, and so on. Now, how do we justify use of these biologics in young age? It is really challenging to determine which patient will be ideal, but a Delphi approach has been advocated. So another question which crosses our mind, does this biologics have a disease modifying effect? Probably yes, because it restores the epidermal barrier function, the skin microbiome status, and probably they will have a long-term effect on the disease outcome. Now, if we look into the history of biologics, intravenous immunoglobulin has been used Gamma interferon, though, has been found effective, but it has not been approved by FDA. Mepolizumab is an interleukin-5 inhibitor. Theoretically, it should have been effective, but studies have failed to show any response. And rituximab has been used at a dose of 1 gram 2 weeks apart with improvement, but the improvement was short-lived. So you can't keep on giving rituximab in patients. So that is again not a choice. So now that we know the cytokines responsible for this atopic dermatitis, we mainly target this IL-4R receptor. My previous speakers have already highlighted on these receptors. So we have this dupilumab, we have tralokinumab, we have lebrikizumab, and then we have nemolizumab, which is an IL-31 inhibitor. Now, dupilumab have been cleared by FDA in 2017, and it has been used for asthma, prurigo nodularis, chronic rhinosinusitis, and eosinophilic esophagitis. And my previous speaker mentioned, Dr. Mehta mentioned that it has been used for chronic spontaneous urticaria. Recently, it has been approved for bullous pemphigoid as well. So this dupilumab actually blocks this alpha subunit of this receptor, thereby prevents the cytokine stimulation. In studies, phase 3 studies, they found significant improvement of eczema in 69% of the patient at 16 weeks, as early as 16 weeks. And there was significant reduction in each score, because that is the main concern for our atopic dermatitis patients. So what are the benefits? It is a targeted therapy. It is not an immunosuppressive. You don't need any laboratory monitoring, and you can use as an adjunctive. If there is associated comorbidities, you use this as well in patients of asthma. And the downside is you have to give it in an injection form. And there are long-term studies which have shown that they are still effective on 5 years use. And recently, dupilumab has been approved by the FDA for using in patients of infants of 6 months and over. The dose is 600 milligram loading dose. Thereafter, 300 milligram given by subcutaneous injection. And it varies in children according to weight. The dose actually varies. But the main problem with this dupilumab is that it have this irritating conjunctivitis, keratitis, blepharitis, which I will come in a minute. So as you can see from this graph, you can see that more than 70% patients has improvement in this EASI score at as early as 4 weeks time. And also there's a significant reduction in the pruritus score. Again, you can note that in 4 weeks time. So is dupilumab is the molecule which will meet our need for the treatment of atopic dermatitis. Now, treatment of dupilumab suppresses the molecular markers of this cutaneous inflammation. So theoretically it should, and it reverses the epidermal abnormalities, leading to a reasonable clinical improvement. And of course, there's significant reduction of itching. But what we have to remember in these trials, the most difficult patients were treated. They have a duration of disease for more than 26 years. They have a mean body surface area of more than 50%. All of them have used either immunosuppressive or the steroids. And 52-week study also showed that this benefit sustained over a period of time. So that is also very important. Now, also there is a study to show that you can use dupilumab in cyclosporin intolerant patients, or where it is medically, where cyclosporin is contraindicated, dupilumab can become handy for us. So used in pregnancy, lactation, or in geriatric patients, we don't have much data, but drug interactions, live vaccines should be avoided, and monitoring required with cytochrome P450 substrates like warfarin and cyclosporin. Now, if you look into the side effects of dupilumab, this conjunctivitis, keratitis, eye pain, ocular discomfort, discharge, these are very common with dupilumab. And funnily enough, these are more common in patients of atopic dermatitis. There have been reports of injection site abscess. Recently, they have reported a lot of cases of alopecia, eosinophilic pneumonitis, dupilumab-associated arthritis. This is probably because you suppress this IL-4 and 13, there's a skewed response to IL-17. Probably that gives rise to this arthritic changes. And also vasculitic rashes have been reported. Now, because dupilumab have side effects, the search is on. So we have other molecules like lebrikizumab, tralokinumab, and ibalizumab. Now, lebrikizumab is moderate. We use it in moderate to severe atopic dermatitis. It's a monoclonal antibody directed against IL-13. And pooled analysis shows favorable tolerability. It's used for moderate to severe atopic dermatitis, as I just mentioned. But side effects are mainly in form of nasopharyngitis, conjunctivitis, injection site abscess. But mostly they are mild to moderate and mostly get resolved. Then we have another IL-13 humanized monoclonal antibody, which binds to this heterodimer. It forms a heterodimer signaling complex and prevents the cytokine release. Again, it is used for moderate to severe atopic dermatitis. And they have undergone 8 clinical trials, which shows reasonably good results. Then we have nemolizumab, which is an anti-IL-31 inhibitor. Now here you can see this this nemolizumab, it binds to this receptor and blocks the action and thereby the cytokine release. And it has been approved by Japan in March 22 and recently by FDA in December 24. Meta-analysis again shows good result, and this is mostly helps to control the itching in atopic dermatitis indicated in 13 years or more age group. Omalizumab, again, my previous speaker mentioned about omalizumab, how it acts, and there have been few studies where they have used this in atopic dermatitis, but we don't have much robust data to say how effective it is. But maybe because of its high cost, we have not been able to use it much, but now that the cost has come down, probably time has come to give it another go. So this is the guidelines laid by this task force regarding biologics. The panel provides strong recommendations for dupilumab or tralokinumab. The available evidence does not address combination therapy. Just now Shoibal was saying that in asthma they have tried combination therapy, but in atopic dermatitis we haven't come across any such recommendation. The panel did not issue a formal recommendation for one agent over other, but the evidence for benefits, however, strongly favors dupilumab as the molecule of choice. Now, a word about this JAK inhibitor is a must when I talk about this atopic dermatitis. We know this interleukins, in order for the intracellular transformation, they need this JAK. JAK or the TYK2 enzymes to transmit their signals, and this they actually transduce the signal for the further gene expression. So if we block this JAK, so thereby this transmission will be blocked, and thereby we can actually control the inflammation. So we have 3 JAK-STAT inhibitors: ruxolitinib, upadacitinib, and arbocitinib. Screening is highly recommended for these JAK inhibitors because these JAK1 are not very highly selective, and this is also present in platelets, in the lipid cells. So we have to be very careful when we use these inhibitors. Arbocitinib is available in India now. It has been approved by FDA for atopic dermatitis more than 18 years of age. The only good thing is that it causes faster alleviation of itch. But laboratory screening is necessary, as I just mentioned, because they can have other side effects. And it is contraindicated in patients with MI, stroke, thrombosis, or retinal or hepatic impairment. They are strong inducers and inhibitors of hepatic cytochrome pathway, and also we need to avoid in pregnancy and breastfeeding. And as you can see, there are a lot of side effects. So definitely we have to be very careful when we use this JAK inhibitor. Now, deglocitinib is a topical JAK inhibitor approved in Japan. Ruxolitinib has been approved by FDA, but even the topical medicines have a black box warning and need long-term follow-up. So the Joint Task Force have recommended use of this JAK inhibitor, that when the patient has moderate to severe disease who are not responsive to conventional treatment, a biologics has failed, or if the patient is also suffering from rheumatoid arthritis, alopecia areata, then this JAK inhibitor can be used simultaneously. Also, we can use this as a brief when we are waiting for some systemic therapy for a short duration, or when there is severe erythroderma, or for social circumstances for a short period of time. And we must not forget this black box warning. So which one to choose among the newer treatment? Arbositinib or JAK inhibitors, though, have a quick onset of action and we can give them orally, but they are broadly immunosuppressive and they have concerns over long-term treatment. And we're not sure yet, we don't have enough clinical experience yet. Whereas for dupilumab, it is a targeted therapy, it has a good safety profile, and the most importantly, they don't need any laboratory monitoring. The problem is the side effects that happens, but this has been, dupilumab has been recently approved by Director Control of Government of India for phase 4 trials in India. So we have to really see in our setup how the side effect profile turns out. So from this busy slide, you can make out so many molecules are in the pipeline. So the future of atopic dermatitis really looks promising, and we do hope that we can put the smiles back onto the face of our patients. Thank you.
Thank you so much, ma'am, for this excellent session. And I'll just quickly see if you have any questions. We are already running short of time, and then probably we can move to the next session.
And I must apologize for my
no
technical
issues, ma'am. That is one thing we cannot control in these online sessions. So, but yeah, we could finish in time. You have enlightened us so much, and thank you for that. So I think we'll move to our next talk, and for that we have one of a very accomplished speaker, and I would like to take the privilege to welcome and introduce Dr. Sergi Douan. He is the assistant professor in Bichat in Paris. He has performed. He has got his medical fellowship in the corneal and external diseases from the same institute, and he's current ambassador of the Tier Film Ocular Society of France and former chair of Ocular Allergy Group of European Academy of Allergy and Immunology. He has authored more than 100 publications and book chapters in multiple books. And a warm welcome to you, Dr. Sergi. And he would be talking about biologicals in ocular allergy. So a warm welcome from India and our association to you, sir. And kindly take over the stage.
Yes, well, can you hear me? It's okay?
Yeah, we can hear you.
Okay, so thank you very much for this invitation. Yes, so this session on biologics is very interesting. It's really a revolution in allergy in general. Can you see my slides?
Yeah, slides are seen and.
Yes. Okay. So well, in ocular allergy, so there are now also there is a
শেয়ার করে রেখেছিলাম আমার স্লাইডটা কিছুতেই সেটাকে আমি করতে পারছি
I can share someone.
হ্যাং করে গেছিল
Yes. Okay. So ocular allergy. So it's a very ophthalmology is a very small specialty in allergy, but we know that the patients can be very bothered and have a poor quality of life. So we have several types of ocular allergies. Seasonal and perennial allergic conjunctivitis usually are not very bothering. The antihistamine eye drops and anti-allergic eye drops are usually sufficient, but in more severe cases like vernal or atopic keratoconjunctivitis, then we can have symptoms of corneal involvement, which can be severe. And these symptoms are photophobia, pain, and decreased vision. So these are the signs that you have to note and that will make you send the patient to the ophthalmologist or to the eye care specialist. In terms of diagnosis, it's not very difficult to diagnose ocular allergy because the signs are the symptoms are very simple. But there is one situation where you can have some problems. It's those children who have inflammatory flares from spring to fall. So during the hot season, spring, winter, summer, and fall, they can have inflammatory flares. And in these patients, very often you don't have any sensitization. There is no allergic mechanism, no IgE-mediated mechanism, and this is vernal keratoconjunctivitis. So you should keep this in mind. This VKC, vernal keratoconjunctivitis, is a very peculiar disease because it begins in boys, usually during the childhood, before 10 years old. Half of them only are sensitized or have atopic background. It's a rare disease, and it increases in the hot season, as I showed, and probably is favorized by the sun radiation. And strangely enough, it disappears after puberty. So, and one of these, the problem is that usually only steroids can be efficient on the eyes of these poor children. So you can see here there are some presentation with what we call giant papillae. So it's a kind of inflammation on the conjunctiva of the eyelids. You have also an inflammation of the limbus, which is here between the cornea and the bulbar conjunctiva here. And these are very typical. And the problem is that they will develop keratitis. Here on the pictures here, they can have ulcers and scars with a plaque and opaque scars. And so it can decrease the vision in these children. So this is a potentially a very severe disease. There is another form of more chronic keratoconjunctivitis, which is atopic keratoconjunctivitis. So this is the form that will occur in patients with atopic dermatitis or very severe asthma, at least a very severe atopic background. And when they have a periocular involvement, they can develop an inflammation of the lids and also of the eyes. And the evolution is chronic, usually in the adult, but you can see also it in the children with this chronic eyelid eczema. And this chronic conjunctivitis, which can be very severe and sometimes with some kind of fibrosis that will look like a pemphigoid, which is not. And the problem is the chronic evolution on the cornea that can involve some of those patients, not all of them, but some of the patients will develop severe corneal inflammation, just like in vernal conjunctivitis. But the chronicity will frequently go to corneal scars and neovascularization, and also they can have complications of infection with herpes and what we call keratoconus, which is another cause of corneal deformation. Keratoconus is a very particular kind of evolution in adults and in children, and is caused usually by the association between chronic inflammation, atopic inflammation, and rubbing. And rubbing of the eye, if you see a patient who rubs his eye very strongly, you should tell him to not rub his eyes, not rubbing the eyes, because he can develop keratoconus, which is a blinding disease. And you should also send him to the eye specialist in order to detect this keratoconus that can be in those patients. And the last problem in these patients who take topical steroids is the iatrogenic complication, such as glaucoma induced by steroids or cataract. So I won't go into details on the topical treatment because it's really a specialist treatment, but I wanted to talk about the impact of biologics. So we have had the opportunity to test those biologics in our patients, thanks to the pneumologist and thanks to the dermatologist, because both of them use biologics that can be efficient in ocular allergy. So what are the targets? There are many targets. You can have IgE, you can block IL-4, IL-13, JAK, and eosinophils, and also itching with the IL-31. I will go into detail on each of those biologics very quickly. So first, when we blocking the IgEs was probably the first strategy of biologics, especially in asthma. And since more than 10 years, we had the opportunity to test omalizumab in children with the vernal keratoconjunctivitis and also in adults with atopic keratoconjunctivitis. This product is not, all these biologics, they are not allowed and not approved for conjunctivitis, not approved for ocular involvement, but in patients who have asthma initially, those were children with a VKC and asthma, we tested these products and in some patients it was very efficient. We have several publications about the current immunological and clinical evidence of this role of this treatment on the cells and on the mechanisms of involved in vernal keratoconjunctivitis and in AKC. I won't go into detail because we don't have time now. But I just wanted to show you, for example, a boy who had a severe VKC with a high IgE, total IgE in the blood. He was sensitized to many allergens, and he has a very severe form of keratoconjunctivitis, and he was resistant to topical cyclosporine. He needed a chronic instillation of steroids, and also he had injections of steroids into the eyelids. He had a chronic periocular eczema, so it's like an atopic keratoconjunctivitis in the child. So it's a frontier between vernal and atopic keratoconjunctivitis. So here you can see the inflammation on the eyelids and on the cornea. And so it was quite a difficult case. And because of his asthma, our pneumologist put him on omalizumab. And you can see that the control of the asthma was very quick after 3 months, and the eczema was also controlled after 9 months. And I show you here the eyelid, which was very nice after 9 months. What about the eye? The eye also evolved very favorably. And so the inflammation decreased. The child could stop some of the eye drops. He had still some inflammation, so the control was not total. It was only partial, but the mean rate of inflammation was much lower. So it became it got to from a refractory form to a treatable form of vernal, which was a good thing for him. And his need for steroids was much decreased. Then we published there are some publications, there are many case series, and you can see here on the left, this is another case series with 2 patients, and you can see the effect on the left patient. It was a total effect during the season of omalizumab, and on the right patient, it was a partial effect, like we had in some patients. So we we published probably one of the biggest series of patients treated with omalizumab. Some of them had VKC, others had AKC. You have and you can see here in this column at the middle, you can see the kind of response, either total, which means that they could stop every treatment on the eye, either no response. So we have 4 patients without response. This is a 18 patient series. So 4 of them did not respond. And you have a partial response in also several patients. So this is what we have with omalizumab. You can see that some of these patients had a partial response, and you can see, for example, here, if you see the N patients, we had a question about does the rate of total IgE, is it a predictor of efficacy or not? You have patients with high IgEs in the blood, and this patient did not respond. And you have a patient with very low IgEs in the blood, and he had at least a partial response. So it is not a criteria for the moment for choosing omalizumab or not in the patients. What did we do in the patients who did not respond? We switched them. I show you the case here, so I will go quickly. You have an inflammation. He did not respond to omalizumab after 6 months, so we switched him to anti-IL-5 treatment, mepolizumab, so which is an anti-eosinophil treatment. We know that eosinophils are very important in the pathophysiology of virulent keratoconjunctivitis. And in this patient, he has also a high FeNO, showing that there was an eosinophil activation in the lungs. So this was our first patient who was treated with a anti-IL-5 treatment. And by the way, he had no IgE-mediated reaction. In fact, he had no sensitization. So logically, he did not respond to omalizumab, but he responded very well to anti-IL-5 treatments. And you can see here the evolution. First line was before, and second line was after treatment. So it was a very nice case. We published this case very recently. So we have 2 cases that now 3 cases of those kinds of patients. Now I will talk about dupilumab, because we know that dupilumab is a very important treatment, a major biologics in atopic dermatitis. And what about the eye? So we have many data about dupilumab and conjunctivitis, and we know that dupilumab can induce conjunctivitis. But what we don't know is if dupilumab can also treat atopic conjunctivitis. And there are very few data in the literature. And here is a case who has been treated with dupilumab. And you see on the right slide that that there is a very positive effect of this biologic in these patients. So dupilumab here was only introduced only for the atopic dermatitis, not for the conjunctivitis, but we can see that it has a nice effect on the eye. So in the literature, there I show you here a French study. So this was a prospective study, and so this study was in fact initiated in order to assess the complications of the ocular complications of dupilumab in patients treated for atopic dermatitis. And in this series, so they included 181 patients, but among those patients at inclusion, 27 of them had already active atopic keratoconjunctivitis at day 0. And what did they become? In fact, 13 of them, meaning at around half of the patients, they improved on dupilumab, meaning that this biologic can have a positive effect in half of the patients. And very interestingly, the others were stable, and only 2 of them developed worsening of the conjunctivitis. So worsening of the conjunctivitis with dupilumab is very, very classical. It's a very frequent effect, probably one of the most frequent side effects of dupilumab, and we have acronyms such as DAOSD or DIOSD, which is dupilumab associated or induced ocular surface disease, meaning conjunctivitis and blepharitis. So it's almost 30%, 20 to 30% of those patients, which is quite high. And you see the clinical pictures, the patients, they will have red eye, conjunctivitis, they can develop dermatitis, very very alike the patients with the AKC, but they usually do not have keratitis like AKC patients. So it's less severe, and it's more on the conjunctival and on the cutaneous side of the inflammation. The mechanism is probably a switch between Th2 and Th1, and there is a very nice recent study that showed that biologically you can have a shift, a biologic shift in the tears of the patients from Th2 to Th1 and Th17 in the tears. Um, so well, this is a really a challenge and an issue, because it does impact the quality of life of the patient. So there are now several publications. We had a publication on how can we manage those patients. First by detecting any kind of ocular involvement before the prescribing dupilumab. And then what can we do if there is a conjunctivitis, or if there is a blepharitis? If you have eczema, I won't talk about this part, but I will just insist on the importance of immunosuppressive treatment with the skin tacrolimus, which is very potent on the lids, and so you must put tacrolimus onto the lids if there is any kind of dermatitis. If they develop conjunctivitis, artificial tears and anti-allergic eye drops, antihistamines, mast cell stabilizers, or dual action eye drops can be sometimes efficient, but usually you will need topical steroids, and the ophthalmologist or the eye care specialist will prescribe topical cyclosporin or topical tacrolimus eye drops or ointment into the eye. I will show you some pictures thereafter. So what if this kind of treatment does not work? So you can increase the interspace between the two injections of dupilumab. There are some studies that show that you can improve the ocular complication if you increase the space between 2 injections of dupilumab. I show you here one patient with dupilumab-induced conjunctivitis here, and we tried the topical cyclosporine, which did not work, and then we spaced dupilumab, and also we put tacrolimus ointment around the eye, but also into the eye, which has a very nice effect. So what about the other options? The other options are now that you can switch dupilumab to pure anti-IL-13 biologics, which means tralokinumab or lebrikizumab, and there are now some evidence showing that the incidence of this complication is less frequent, switching from 20 to 30% of case of complication in dupilumab versus around 10% with tralokinumab or lebrikizumab. So the frequency is less, So this can be interesting, but usually the effect on the skin, is also less interesting than dupilumab. And the other option is to switch to JAK inhibitors. And usually you don't have any problems with these new treatments. And this is a very nice way of treating a patient who is very recalcitrant and who has a complication, ocular complication with dupilumab. I will go very quickly on this study of a French group on atopic dermatitis, and they studied here. You can see in this table. They switched from dupilumab because of the eye to tralokinumab or to JAK inhibitors, and you can see the percentage of patients who resolved their problem. So with tralokinumab, you have 72% of the patients who responded to the switch and who were happy with it, and 92% of those patients treated with JAK inhibitors. So you can see the rates of success. The problem was the lack of efficacy and the decrease of efficacy concerning the systemic control of the atopic of the skin disease, because you had a 20%, 25% of discontinuation with tralokinumab and 44% of discontinuation with JAK inhibitors because of lack of efficacy on the skin of those patients. So the last biologic, and I will conclude with this, is anti-IL-31, which is very interesting for pruritus, for itching, and in the eye, it could be very interesting for preventing keratoconus, but we don't have data for the moment. So they are really a revolution, these biologics for allergy, but they are not approved for ocular allergy, but it's really very interesting for several forms of ocular allergy, and this is just the beginning of the story. Thank you very much.
Thank you so much, Dr. Sarji, for this lucid presentation, extensive, and it was very interesting to see your own work, your experience in cases, which made us learn a lot. And thank you for taking us time for our for this webinar series of us. And we are very thankful to all the galaxy of experts we had today. From Dr. Vinay to Dr. Sharbani, Dr. Saibal Mutra sir, who has been always guiding us, Dr. Sarji. And I would also like to thank the PI Association, the chairperson, Dr. Neeraj Gupta, for bringing this such a extensive series on biologics, because these are always things which we have been confused. We have been and now in these 3 days, we are really enlightened a lot. And I think I can see some question from Dr. Neeraj. So,
yes, so should I answer? Yes. So, the first question is, which pathway is involved in the pathology of vernal keratoconjunctivitis? Well, it's a mix between Th1 and Th2. So you have IgE-mediated reactions, but you have also several other reactions involving the Th1 and Th17 pathway. And other reactions that we don't really understand, but the main efficient the main cells that are involved are mast cells and eosinophils, and also lymphocytes. So it's a mix between IgE and non-IgE reactions. So there is a question about side effects of dupilumab in vernal keratoconjunctivitis. Well, we don't have in children you can have side effects of dupilumab. So usually patients who are on dupilumab with vernal keratoconjunctivitis are patients who have also atopic dermatitis, severe atopic dermatitis. So it's a frontier between vernal and atopic keratoconjunctivitis. And dupilumab can also have this kind of side effects in children, but usually it's less frequent than in adults. And this has been shown in series. So I very it's not frequent to see a patient with a vernal and complications, ocular complications related to dupilumab. But it's the same mechanism as in adults.
Thank you so much for taking the questions. And I think before we call it a day, I would request our chairperson, Dr. Neeraj, to have his final words.
I think I'm very thankful to every one of you. All the speakers for all the 3 days. Actually, it is really very difficult to say any word to say thank you. All the sessions have been really super. And before the onset of this series, there were a lot of confusion, lot of questions which always people used to ask about biologics. And now we try to, you can say, like, open up each and every condition, each and every biologic, what are the plus, what are the minus, where we are, when we should think of, when we should not, and what things we need to monitor. And the good thing is that all the stalwarts across the globe, they all have participated in this one. And I especially like the sessions by Serge, by Dr. Vinay, Dr. Joha, and simultaneously Dr. Sabal sir. All the sessions were really extensive and great. Thank you so much from IAP Allergy and Applied Immunology chapter. We are so grateful to all of you. And special thanks to Dr. Sonia Bhatt for accepting our invitation for moderating today's session. Thank you so much. Thank you.
Thank you so much for this opportunity, Dr. Neeraj. And if we have time, we'll just take a last question. I think there's one question from Dr. Rishali for Dr. Serge. It is, as it has the IgE and TCL mediated pathway, do you do allergy testing in every patient of VKC of vernal keratoconjunctivitis? This question is for you, sir. Do you do allergy testing
Yes.
in each and every?
Yes. I think it's very important to test allergy. In fact, in VKC patients, allergy can be a worsening factor. It's usually not an etiologic factor, but it can be a worsening factor. So it's important to know if there are some pneumoallergens that may be responsible for an increase of the inflammation, for example, during the pollen season, or for example, in the patient who has a perennial vernal keratoconjunctivitis, very usually they are sensitized to perennial allergens such as dust mites or a cockroach or some others. And in those patients who are sensitized, it can be interesting to make a specific immunotherapy, especially if you have the conjunctival provocation test. Which is available in some countries and not in others. In France now it's not available anymore. But the problem is that when you test those patients systemically for the prick tests or for the specific IgEs, it's not always what happens on the eye. So it can be not relevant. And this is why the local tests can be interesting, but it's always interesting to do the allergy test in all those patients with ocular allergy, of course.
Thank you so much. So I think, yeah, we have sorted out all the queries, and thanks a lot. So I would say good night to all the dignitaries over here, all the people, all the delegates who are watching on YouTube Live, and thanks a lot again for this opportunity, Dr. Neeraj. And good night, everyone. Take care.
Thank you very much.
Thank you.
Thank you. Pleasure.